Thanks so much, Denny. And before I start talking about Patients First and the Patients First Act, a couple of important things I want to do. The first is to ask members of the Board of Health Sciences North, would you mind just standing up for a moment, please? Ladies and gentlemen, most of us are being paid to be here tonight. These folks are volunteer leaders of this hospital community. Thank you for the work that you do. And I'm going to talk about the importance of hospital boards and hospital leadership in our healthcare system. The other thing is just to thank Dr. Roy and members of the Health Science North team, Dr. Koka and others, for the way that you stepped up to the plate to help so much in facing the challenges in Attawapiskat. Literally a real crisis, a real risk to the Ontario healthcare system. I'm going to talk about the healthcare system for Indigenous Ontarians and your experience and your willingness to both learn and to serve in a different way. Very much appreciated. Denny, thank you very much for that. So I apologize. I'm not going to embarrass myself or insult you by trying to speak in French tonight. I apologize for that. I'm just terrible. But it is a real pleasure to be here. Thank you so much for the warm welcome you've provided. And what I want to talk about is the legislation that Minister Hoskins tabled in the legislature a couple of weeks ago, the Patients First Act. I want to talk about what problems we're trying to address, what's the reason for the Patients First Act. I want to talk to you about 4 principles that started off underlining the Patients First Act, and a 5th principle that became evident to us during the process of consultation. I want to tell you what we think the implementation plan will be, and very briefly over the next year, anticipating passage of the legislation. But most importantly, I want to get your feedback. I've been at a lot of different dialogues like this over the past 6 months as we built up toward Patients First Act, and I must say there isn't one meeting where I haven't learned something from the questions and the comments that come from the audience. Really appreciate that members of the CCAC are here tonight. Ron and Richard, thank you so much for coming. Really appreciate it. Look forward to your comments. So, Patients First, what's it trying to address? The one thing I learned when I came to the ministry 2 years ago, I've been practicing in Ontario as a GP, emergency doctor, surgeon for 40 years. When I came to the ministry, I learned that we know a lot about what Ontarians think about the health care they receive. We do about 20 to 25,000 long-form telephone interviews with Ontarians, and we've done that for years so we can track the way that Ontarians think about the way their system performs. And it's interesting to go back and look at how Ontarians were thinking 12 years ago, 15 years ago, compared to their concerns and their feelings of comfort about the system today. 12 to 15 years ago, folks were reading, front page Toronto Star that people were actually dying while waiting surgery on the cardiac surgery waiting list, that people were being sent out of country for routine breast irradiation treatment that wasn't available in Ontario. And people, we learned in interviews, had a real concern about whether their health system would be there for them when they were severely ill, when they needed cancer surgery, if their mother needed a total hip operation, would she have to wait for 2 years? These were the concerns that folks had. And those issues related to resource adequacy, capacity, wait lists, I won't tell you they're solved. I mean, we can do better, there's no question. We recently had patients requiring stem cell therapy, for example, where Ontario resources just got behind the progress of science and clinical opportunity. We are now sending patients to the United States for stem cell therapy. It'll take a couple of years to catch up with the resources here. So we can always do better. But Ontarians today, when they talk about the healthcare system, they think, I think the hospital system is reasonable. I know it may be overcrowded, but I understand that our wait times are better. And I think the problems that beset the hospital sector 10 years ago, C. diff outbreaks, uncertain quality, a lot of those problems have been solved, and a lot of those problems have been solved because of governance of hospitals. The Excellent Care for All Act that insists that a quality committee of the board holds Dr. Roy and his team to account for the quality of care here. The development of patient and family advisory committees, congratulations. You're leading the way in having a patient-family report at your AGM. These things have improved the confidence that Ontarians have in their hospital system. And I can tell you from the data that we gather, the Ontario hospital system is a safer place that's more cost-effective and more effective than it was 10 years ago. So what are the concerns? We hear from Ontarians relative confidence that the hospital system will be there if I need it. Ontarians also 10 years ago said, really disappointed that I don't have a family doctor. 10 years ago, only about 70% of folks had a primary care provider. Today, that number's improved dramatically. We've got more than 90%. I don't know what it is in this area, but more than 90% of Ontarians have a primary care provider through a variety of different models, through family health teams, a couple of excellent family health teams here, through community health centers, through nurse practitioner-led clinics. A variety of different methods of primary care have developed, and over 90% of Ontarians have primary care providers. But what we hear on interviews with Ontarians is also reflected in international statistics about performance in the primary care system in Ontario. And what we hear people say is, I'm delighted I got a primary care provider, but I can't always see them when I think I need to. And sometimes if my daughter's got a fever when I get home at night, I call primary care, I can't get an appointment for the next few days, and I end up going to emergency in order to get treatment. And if we look at international statistics done by the Commonwealth Fund, the US organization, looking at performance across primary care, Ontario ranks 10th out of 11 wealthy Western countries. The only country that's worse than Canada and Ontario is the United States, where we have less access to primary care using a metric of, do you have to go to the emergency department to get care because you can't get an appointment with primary care, or using the metric of, can you get access to primary care when you need it, when you think is an appropriate time. So this is a problem that Ontarians relate. And it's not that we don't have great primary care doctors, we do. But our system is not planned or organized very well to suit the needs that Ontarians have today, not only for care, but also for service. Let's face it, we're looking for more service today. A similar thing, Ontarians talk about access to care across home and community. And they say, it's difficult to understand, it's hard to navigate. My son was showing signs of unusual behavior. I knew that they needed to see a mental health provider. I eventually got to see somebody. There was mental health service available in our community, but it took a long time to get there. And it was worrisome. It wasn't easy to find my way there. It wasn't really easy to navigate the system. And that word we hear a fair amount, both from providers and from patients. Hard to navigate, hard to know, hard to understand. It's complicated. So these are issues that Patients First is designed to address. The other issue is the issue of health equity. And I think we all recognize that healthcare to Canadians is more than just a service. It represents our culture. It represents how we care for each other, and it represents our principles and values. And I think one of the things that we all believe is that in the Canadian healthcare system, care should be available based on your need as opposed to your ability to pay. That's something that we use to differentiate ourselves from Americans. Canadians are Americans who have health care and don't have guns, right? That's the way that we sometimes define ourselves. So that's what we like to believe. In point of fact, if you'll look at the truth, if you look across Ontario and you do a heat map of wealth in our postal codes and chronic disease in our postal codes, the one thing is true is the wealthier the postal code, the less the prevalence of chronic disease. The poorer the postal code, the more people with chronic disease, diabetes, heart failure, chronic pulmonary disease. So if you were actually distributing health resources in an equitable way, you'd say that poorer postal codes should have more health services because that's where the sicker people are. And of course, if you do another heat map that looks at distribution of health resources, it's exactly the opposite from what you'd want to see. The richer the postal code, more the number of pharmacies, primary care providers, physiotherapy clinics. We don't have an equitable distribution. So these are the 4 issues that Patients First is designed to address. The issue of organization of services, the issue of how we distribute resources in a more equitable fashion. And we've done some learning in the Ontario health system, improved performance in hospitals, improved performance in the cancer system. We've learned some lessons, and some of these lessons we're trying to apply here with Patients First. The first lesson is a basic management principle. If you're going to improve the organization of a complex system, you have to have one point of accountability. One board responsible for integration of services. And if you look at our current system, despite the fact that we got great people serving on the CCAC boards, thank you, Ron, we've got 2 boards responsible. We've got a LIN board, we've got a CCAC board. And one of the first things we're saying to Patients First is there needs to be a single point of accountability. And that, for all the services, would be the LIN board and the LIN CEO. Not serving as a health service provider, but a planner and integrator responsible for making these services more navigable. The second thing we're saying is that we've got spectacular people in the home and community system now who are focused on coordinating home care. And if we can make home care a more rational system for distribution, standardization, best practices, we can allow the 5,500 to 6,000 care coordinators currently working in CCACs to do a more diffuse job, to do a broader job, looking at coordination of services across all of home and community care instead of the slice of only home care. To do that, bringing CCAC employees to work for the LINs, responsible for home and community care coordination, working as frequently happens today, and I know it happens in your LIN, focusing care coordination in hospitals for post-discharge home care, focusing coordinators in primary care environments, happening increasingly across the province, for patients who require home and community care focused in the community, having those coordinators as part of primary care teams. So that's the first change. LIN as a single point of accountability, CCACs coming together within the LINs, their employees moving to the LINs. The other thing is that planning care in a local, regionally responsive way across all the Northeast LIN is clearly impossible. Too many different environments. We have to have regions which are autonomous where we can think about planning services. Sudbury obviously would serve as one of those areas, Timmins undoubtedly, North Bay, Sault Ste. Marie. You've already got the areas defined, but other LINs haven't done that as well. Thinking about the organization of healthcare resources within LIN sub-regions. Hi, Kevin, how are you? Kevin Funnell you work here, don't you? Kevin, I've known Kevin for 100 years. I won't tell you how. But anyway, it's nice to see you in the audience. Hi. So anyway, where was I? LIN sub-regions. Built on the model of health links, which are increasingly successful at dealing with the issues of complex care patients, bringing together comprehensive care plans for people with complex care needs, looking at that geography as something that can organize care, not just for the 5% of most complex patients, but for all patients who need access to the system. Obviously, less access when they're less complex, but thinking about those geographies which bring together mental health and addictions resources in community, community support services, home care services, primary care services. The third change is around primary care. Because I think if you look at any high-performing health system, it's built on a very strong foundation of primary care. And we have very strong primary care providers in Ontario. We've got some of the best physicians in the world, some of the best nurse practitioners providing primary care. But guess who's responsible for planning primary care in Ontario? I think I am. And we don't have the kind of local intelligence we need as to how many patients in a region need access to primary care, how many people are looking for a primary care provider, how many primary care providers are involved in integrated comprehensive care, how many are working in long-term care facilities, taking emergency shifts, how many have room on their rosters to take new patients. So this kind of local intelligence that allows us to plan for primary care recruitment, primary care organization, is a crucial piece of a stronger health system, and it's a crucial piece of patients first. And to do that, one of the lessons learned through various reforms in the Ontario health system is you can't do that from the LHIN. You need to do that by engaging the clinicians who have the expertise about what's happening and what should be happening in their communities, in their LHIN subregions. So Patients First speaks to the issue of recruiting primary care thought leaders, people with clinical credibility who can give advice, work maybe 30% of their time, alongside a full-time director of integrated care who's responsible for linking patients up to primary care providers, who's responsible for making sure that patients who need complex care are being directed to coordinators of home and community care, who's responsible for organizing the local system, looking at the terrific resources in hospitals, thinking about how to get access to the diagnostics, to the secondary care specialists in hospitals, someone responsible for integrating care within the Sudbury community, working with the terrific people who work here and saying, how can we make sure that everybody in this community is getting the integrated care they deserve? So that's the third element of change suggested in Patients First. The fourth element relates to health equity and population health. And your organization is a leader in this regard. You're thinking already of the population health needs for the communities that you serve. Many of our communities across Ontario are not thinking that way. They don't have a sense of what goes on outside the four walls of the hospital. So one of the fundamental features of Patients First is to try to bring that population health understanding and expertise that lives in the boards of health, that lives in the public health units, that lives at Public Health Ontario, to bring that to the LHIN senior management table to help us plan resource distribution in a more equitable fashion. And nowhere is that more evident than in rural communities, and especially Indigenous communities across Ontario. And you've heard our Premier, our Minister, absolutely committed to understanding better how to improve the health experience and the lives of folks who live in Indigenous communities, both in urban settings and on reserve. That is really the fifth element of Patients First that became evident during our consultation period. So Minister Hoskins tabled a discussion document in December. We got feedback from over 7,000 Ontarians, face-to-face meetings, reports submitted by various organizations. We got a huge amount of feedback. And one of the areas that we got feedback was from Indigenous communities who said, when you established LHINs in the first place, you didn't really ask us. Didn't ask us how we wanted care to be provided. Don't make the mistake a second time. And we know that Indigenous Ontarians, if they need heart surgery, are going to come here. If they have needs within the hospital sector, they're going to use resources managed by the LHINs. But we also know that the chronic disease, the mental health concerns related to intergenerational trauma, related to many generations of colonial political impact on Indigenous Ontarians need to be addressed by recognizing the kind of health system, the primary health system that they work through. And we've seen a lot of success with things like Aboriginal Health Access Centers. As we expand the primary home and community center approach for Indigenous Ontarians, we're going to look at a separate way of devising their primary care system based on the kinds of combinations of traditional healing methods with Western medicine, based on culturally safe care. That's the fifth element that's become very important in Patients First as part of the reconciliation that we are committed to in Ontario with Indigenous Ontarians. So those are the five elements of Patients First. And frequently I'm asked when I'm speaking at general meetings of hospitals, so you didn't say anything about hospitals. Aren't we part of the plan? And, you know, there's been a huge focus on hospitals for many years. The Excellent Care for All Act, a variety of areas where the government's focused on hospital care, investments in cardiac care, cancer care, all necessary, all important. But I think now focus on planning and performance in the home and community and primary care setting. I think we need to catch up. How hospital leaders, and Dr. Roy is a great example of this, are thinking about it is how can we lead from behind? How can we actually organize our resources to serve better integration of our care in the hospital into the home and community? How can we keep people out of the hospital by organizing better integrated care of their congestive heart failure with telehome care, with home monitoring, with engagement of home and community care? How can we keep people from needing to come to our emergency department here? So there's a huge role for hospitals to think in an innovative fashion, not just about how do we improve quality, how do we improve performance inside our four walls, how do we take that expertise in quality improvement, because you are the areas of focus. I heard it today. Your focus on quality improvement is so impressive. How do you push that out? How do we get that story out into the community? How do we engage the community in actually providing the kind of integrated service that would make a hospital a more effective part of the system? So those are the changes that we have in mind. Some of them are controversial. You know, some physicians are saying, you know, listen, I've got a small business, I've got a practice that's independent. I've built this practice, you're not going to tell me how to run this practice. And under no circumstance do we want to tell you how to run a practice. What we do want to know is we want to know if you're accepting new patients. We want to know if your office is open over Christmas so that we understand who's going to be open, who's going to be closed. We want to understand what the system of primary care looks like in a community. We also want to know if we need more primary care providers, and if we do, what kind of primary care providers? Working in walk-in clinics, working in comprehensive care. How do we plan the appropriate model for primary care delivery in any given community? So, you know, that's what we're planning. There's been concern expressed by some hospitals that we're looking at eliminating hospital boards, potentially eliminating the important aspect of self-governance in Ontario hospitals. Absolutely not. This is one of the strongest parts that we have to build on. No desire to do that whatsoever. Concern about faith-based hospitals, where we're trying to eliminate the principles that underline faith-based care, the mission of faith-based institutions in Ontario. No desire to change that whatsoever. That's, again, a strong historical part of the Ontario system that we hope to keep there. We're talking about building on the home and community part.